Just waiting for the go ahead.
Should we get started, Dr. Mohammed?
Admit a few more people to accept. Mirza, welcome. How are you? I think only Corina. Good. Did not.
Yeah, Dr. Karina said she's going to be a little bit late. So we don't have to wait for her.
I think we can start today's webinar. It is together with the WFNS Education and Training Committee and what was the name of the the other committee?
Innovation and Technology.
Innovation and Technology Committee. And I will leave the scene to Dr. Teresa Williamson and Dr. Mohammed Abdelbar for these very interesting topics. Yes.
Perfect. Thank you so much. And
they will be the moderators.
Thank you so much, and welcome everybody to this webinar on augmented reality, robotics, and so on. It's a great pleasure to be here with all our friends and colleagues from all over the world. And we're going to get started with this webinar with she's supposed to be my mentee, but I think she's more my mentor because she teaches me more than I learn, or that I teach her, Dr. Teresa Williamson, who's an assistant professor at MGH, and will be talking to us about augmented reality as it relates to spine surgery.
Thanks so much for the introduction. I'm going to go ahead and play a pre-recording, but I'm here to answer any questions. I just didn't want too much background noise this morning. So I'm going to go ahead and play it. Just make sure you can hear it. Thank you so much for coming to the conversation started about my experiences.
Cannot hear the voice.
Sorry, but there is no audio.
Yeah, I'll talk about the basics of the setup and workflow in case you're wondering how to use it. Obviously, you can get more detailed training about how to use much for coming to the WFNS Education Symposium. We're going to talk about virtual reality. We're going to talk about robotics. We're going to talk about simulation today. Just really excited in general to get this conversation started about my experiences at MGH with augmented reality. I'm Teresa Williamson. I'm a neurosurgeon at Mass General Hospital. And today I'll be talking about simplifying surgery and using augmented reality to help simplify complex procedures. I'll talk through some cases, and show you how I think this technology can be incorporated amongst other technologies that I use in taking both a minimally invasive but also complex approach to the spine. I don't have anything relevant to disclose to this talk. For an outline for this talk, I'll talk about augmented reality and spine surgery. I'll talk about the basics of the setup and workflow in case you're wondering how to use it. Obviously, you can get more detailed training about how to use these types of technologies, and I would recommend doing that if you want to use them. But I think just going through what would it look like in your OR, and then maybe some of the reasons why I would use augmented reality. So to start with what augmented reality is in spine surgery. So augmented reality overall is an experience where designers enhance part of the user's physical world with computer generated input. So if you think about this from a video game, from an experience test driving a car in augmented reality, we're bringing some of the computer world into our physical world so that we can better understand in 3D form what the world is looking like. For a surgeon, it allows us to quote unquote see the patient's anatomy through the skin and tissue as though we have X-ray vision, and be able to really look and accurately navigate spine procedures. And the nice thing is it's right there in our real world, in our view, as we're working. And so I'll show some examples of that next. So there's no footprint in the surgical field. There's no, I have to put a chicken foot or however you call your navigation guide into the field. You're just looking, you're using those glasses. You can see this white headset here, and you're looking down at the field. You're seeing that superimposed computer generated image as you're using your driver or whatever instrument you're using. This is how the image can look when you're up on the screen. You can have, pretty substantial detail, and you can also change your viewpoint. And so this is a sagittal view, axial view, and then you can also look in 3 dimensions. I do like that 3-dimensional view. It gives you an opportunity, I'll show you, to use it beyond just placing pedicle screws. I think there's some really other interesting ways to use this technology when you get to rotate that 3D model in real time in your glasses. So it's flexible. You can use it for multiple different instruments. Here's an example of using it to place a K-wire through a Jamshidi K-wire tap and screw technique. And so looking at that navigation in real time and using it on multiple different instruments, because the adapters can typically adapt to multiple different instruments. So going into the workflow, the first step is to place a patient reference marker, and then you're going to do an intraoperative 3D CT scan. Once you do that, you'll have the headsets. I typically would scrub out to put on the headset, only because it's heavy, I think, to wear for the entire case. So if there's a part where I want to use augmented reality, I would typically have the team scrub out. One of the things about this is the case we're doing together. And you can see that 3 of us are wearing headsets, but actually only 2 headsets are live at a time, just based on the limitations of the current technology. That is one limitation, especially if you work in a teaching hospital like I do, because it can make it a little bit more difficult for the trainee to also be seeing, or multiple trainees to be seeing. And so there is a screen also in the room to show your trainees what's going on. The great thing about that is once you have this augmented reality, your eyes are always on the patient. So you're looking down, your reference array is in the field. You don't have to have a camera or another eye being able to see you, and you can see everything in real time. This is the setup as it looks in our OR. So here's the O-arm spin coming in. Here's the augmented reality screen to capture and get that those reference images. And then we have the rest of our surgical setup. So how do we actually use that in reality? And so I have found it really helpful to augment or to add to some of my cases that I already am either worried about challenging anatomy or want to be more efficient in my approach for any particular reason. And so I'll show you some of those cases. So this was an interesting case of a 49-year-old with sickle cell disease who had congenital autofusion all the way from the occipital cervical junction, and then a large upper cervical autofusion, and then at the mobile segment at C7T1 between the cervical and the thoracic spine. One of the remaining mobile segments in his spine, he had developed severe disc degeneration as well as ligamentous overgrowth, resulting in cord compression, cord signal abnormality, and a really pretty acute progressive cervical myelopathy. And so for this case, because of his sickle cell, he had long-standing history of sickle cell. He'd actually done very, very well for almost 50 years, but he had developed a lot of collateral vessels. And so it was a really tricky case to navigate where we were going to put screws. This is an example at T1. You can see these large feeding vessels, way more vascular than typical at the pedicle, and potentially with collaterals into important cardiopulmonary structures. And so we wanted to make sure that we were really accurate in where we were navigating these screws. So we got good fixation, good ability to put the screws in, and then also ability to do the decompression. I should note that actually, because of his immobility of his cervical spine, they were unable to approach anteriorly. He had a trach for a year from a prior surgery. And so our ENT folks were unable to give us anterior access safely with his airway. And so that's why we had to do a posterior decompression infusion. And so this really helped us to work amongst those limitations, can't go from the front, need to go from the back, multiple vascular collaterals. And so looking in real time and being able to see that CTA, as I showed on that prior slide, while we're placing the pedicle screw, really did make that case go more smoothly. He's done really great. He's almost 2 years out now, and has not had a problem, regained his ability to walk and be independent, and is really happy. So here's another example of where challenging anatomy or situation can be aided by augmented reality. So in this particular case, this is a 75-year-old with osteoporosis, progressive height loss, and retropulsion. She had had a kyphoplasty at 2 levels prior. The second level had a near vertebra plana and actually retropulsion of the cement into the canal. And so in this particular case, we wanted to be able to complete a VCR to help with her alignment a bit, but also to get that retropulsed cement out of the canal. And so this was a case where we wanted to be able to both see for placing our screws, so we could get a good pedicle screw around the cement above and get an extra point of fixation in a patient who is pretty medically sick. And we also didn't want to make multiple pass or tracks in someone without very strong bone, and then also use it to navigate the drill, which is an off-label use still at this point, but to help us to drill off that cement fragment, obviously in a very sensitive area. And so this is an example of using the augmented reality to help us to place that screw just up to the cement, and being able to see that in real time. And then I'll show you later on, as I show a different case, how we did it for the bony work and drilling off the cement. So she also ended up doing quite well. When we have difficult angles, this technology can also be helpful. It's kind of interesting. This is not a case that I would do or be in a situation that I would be in all the time, but this is an example of when, taking a different technology out of your toolbox might be helpful. And so this was a 50-year-old woman who had just an absolutely miserable 6 months of refractory pain, inability to walk, multiple trips to the hospital, multiple rehab courses, tons of physical therapy, an attempt at weight loss, medical management, and bracing, and just could not get ambulatory due to this bony chance fracture at L2. And just inability to stand up or bear weight. And so finally, she was transferred to our hospital for an attempt at stabilization. I was really concerned given her size, actually. We were unable to get good x-ray pictures so that we could, see well. And then it was going to be really difficult to navigate, to have a patient array visible, to get her through the O-arm, and then also to have the patient eye see the reference array at the same time that it was seeing our instrument, just based on the depth of the working field. And so I do think that augmented reality made this case substantially safer and easier to do. This is a different case example, but what we were able to do is open to the fascia, put on a spinous process clamp, and then we're only looking down at our clamp. We don't need a camera to see over her subcutaneous tissue in order to do that. And so we were able to place our screws safely that way, and she ended up doing quite well. You can see here where you can actually see through your glasses and you're looking straight down at that patient array. And that was really, really helpful in this case. She's done really, really well. This was an older slide, but she's now out about 2 years. And so this is another example when you want to be efficient in a big case. I think it's also helpful. This is an off-label use, again, of using augmented reality to navigate the drill. And so this was a patient with a upper lobe Pancoast tumor that had invaded the spine around C7, T1, and T2, T3. And so we ended up doing this is a case that I did with one of my partners at the time, John Shin, where we exposed a large portion of the cervicothoracic spinal cord to make sure we had a good wide decompression. You can see the tumor here. You can see the T1 nerve root with the yellow band, and the T2 and T3 nerve roots that had to be sacrificed due to their involvement with the tumor. And so we were able to actually take the take the tumor and resect it away from the cord, but then we also needed to make a vertebral body wedge cut so that we would get a gross total resection, which is really important for prognosis in patients like this. And so we actually then scrubbed out, put our headsets on, and navigated the drill in order to make an exact wedge cut where we knew tumor was infiltrating, so we could, at least based on imaging, try to get that gross total resection cut. And then our cardiothoracic surgeons were going to come the following day in order to be able to actually resect the rest of that tumor anteriorly. And so here's an example of and this is the CT scan example of where that wedge is, and you can see the exactness. And so it was very efficient to be able to have that marker on the drill and just be able to work right in that plane without having to look up multiple times, check where you are on imaging. And so this is kind of where we get excited about, okay, what can we do in the future with this type of technology? Because then we were able to combine with a robotic approach. This is one of my cardiothoracic partners, Hugh Auchincloss, who then was able to resect the rest of the tumor off of the vessels from the front and complete the gross total resection, removing that tumor anteriorly in a robotic fashion. And so this is the tumor when it came out on block. This is the post-operative fusion. Patient had a long hospital stay, but ultimately discharged to rehab, is now over a year out, just doing fantastic, no recurrence of disease. Going back to how we can use this for confirmation. So this was another bony cut. This was that prior case that I had showed you where that vertebra plana existed, and we wanted to do a vertebral column osteotomy there. And so this is, again, using that drill to do that and being able to get improved kyphosis on that correction, as well as drill out that cement fragment, which was really the goal of that case, to prevent her myelopathy. And so going back, that's what we reviewed, is how we could look at different case examples of when to integrate, when to pull augmented reality out of your toolbox and use it. And I think there are some really great and interesting times to do that. So, thinking of this in general, I'm excited to imagine the possibilities of what we can do with augmented reality. I think there's a lot we can do. I think it's not the only technology we can use, which is why I'm excited to have the future speakers, because I think that they'll be able to help us understand how we can use other technologies as well. And ultimately, you can choose what's in your toolbox for what's best with your case. So I'll take any questions. I'm happy to be here. And again, excited for our others,
Thank you so much, Dr. Teresa. That was amazing, as always. Because of time restraints and so on, maybe we'll have time for 1 or 2 questions.
I have a question, if possible. In your opinion, is more valuable to use the navigation or the augmented reality? Because it seems to have an integration between navigation and augmented reality in your cases. And if yes, what is the plus of the augmented reality with respect to standard navigation?
Yeah, so I would say for my everyday case, I'm still using navigation. I'm either using the robot or I'm using navigation guidance. And so I think the benefit to this case is in some of those examples where it's just a little bit, you have that, okay, I really want to have my vision on the field the whole time. I don't want to be looking up. I don't want to, I want to do it for my osteotomy cut, or I have difficult anatomy and I want to be able to just be sort of focused the whole time. Otherwise, I think the technology, just to be perfectly frank, in my opinion, like the headset's a little bit heavy. You have to scrub out. Only 2 people can wear the headset. So there are some technical limitations still at this point. I do think once it's fully integrated into like a, glasses type of a thing, then it will be so easy that you could wear it the whole case with your loops. And I know that's coming. And at that point, I think it'll probably challenge me to probably shift my practice a little bit to use augmented reality all the time. At this point, because of some of those technical limitations, it's still more of an add-on special case in my practice, at least.
Thank you. Probably is more valuable in a percutaneous procedure because you're able to understand really the three-dimensionality of the anatomy in respect an open surgery where navigation probably is enough. But it's just an opinion because I use navigation but not augmented reality, so I'm very curious about this.
Exactly. I think that, that one thing where you look up at the screen and your hand kind of tilts down a little bit and you're constantly sort of readjusting for perc cases, I think that looking straight down does take away a little bit of that. So there's some benefits. You just have to balance them with having another technology and workflow in your OR.
Thank you very much, Teresa.
And Dr. Teresa, right now, that technology is only using CT. Is that correct? Is there work to combine MRI in there as well, or not yet?
Yeah, so you can actually, if you upload, you can layer other images and merge. So I did for that one case layer the CTA with the CT. Still not quite there with MRI, but I do think that's coming. And so I did like it for, even though it's an off-label use, navigating with the drill or things like that when you're looking around structures, when you're doing a tumor resection. I think that's coming for sure.
Awesome work as always. We'll move on to our next speaker, Dr. Mirza. He's going to be talking to us about augmented reality as it relates to the microscope.
So, hello everyone. Can everybody hear me and see me?
Yes.
Okay. So, Mohammed, all participants, faculty, dear friends, thank you for inviting me. Good afternoon from Marburg, Germany. It's not going to be easy now to hold a good talk on augmented reality after this great presentation by Teresa, but I'm happy that it revolved more on instrumentation and less on these microscope applications. We started 6 years ago with this. So ICT was bought in our clinic in 2016, and we started with augmented reality in 2018. And we concentrated not only on cranial things, but also on spine things. And there are some maybe interesting things to show. So my name is Mirza. I'm born and raised in Bosnia, but I work in Germany for the past 11 years. And this is the city where I work in Marburg, just 100K north of Frankfurt. I show this every time because it's not very well known in the world. So these are one of the last publications from our department on augmented reality. So for acoustic neurinomas, for intradural spinal tumors, and prior, which are relevant for this webinar, intraoperative ICT-based navigation, augmented reality for lateral approaches, and for resection of herniated discs. So we use low-dose protocols with our intraoperative CT. They allow significant reduction of the ED, and the workflow is described in one of our first papers on augmented reality when we've implanted screws in the C2 fractures. It was published, I think, in 2019 as a technical note. And since then, we kind of developed several applications which are for operative microscope only. We use Kinevo from Zeiss. So what is augmented reality? A significant advance, which provides a real-time image overlay of three-dimensional structure, of segmented two-dimensional structures on the three-dimensional field in the intraoperative microscope. First papers came out in 2013, 2016, mostly as case reports and as proof of principle. When we first get the gadget, we were doing this. We took a model, we would do a CT of the model, then we would do a segmentation of a vertebra and of the nerves, and then we would create a three-dimensional image which was then reproduced in the operative microscope. So the workflow is that you put the patient, you position the patient on the table, you put the reference array on the patient, you do the intraoperative CT, and then you fuse the preoperative imaging with the preoperative imaging. You have the pre-segmented structures, and these pre-segmented structures of interest are then superimposed on the binoculars of your microscope. So this is our last publication on use of it in the lateral approaches for the spine. This was a resection of a herniated thoracic disc. the patient is positioned on the lateral decubitus side. You do the X-ray for the level localization. You go laterally onto the spine, and after that, you usually put the reference array proximally to the field. We do not attach it to the pelvis. We just kind of taped it proximally to the operative field, and then we do the intraoperative scan. And now you have the preoperative images where you can segment the vertebrae and the herniated disc and the spinal cord, the dural sac, or whatever structure of interest you have. And then you can fuse these pictures with elastic and with rigid fusion with the intraoperative imaging. And then you get, when it goes to your microscope, a real-time image of the structures which you are operating. You can check the navigation accuracy. And again, the question of Francesco right now was navigation or augmented reality. I would say both. You know, there is no good augmented reality if you do not have a very high accuracy of navigation. And as for the question, in which cases do we use it? We used it in the beginning in almost all cases because, in our opinion, it's good when you have a new technology to try it out on a very simple and straightforward case. And in that way, then you can use it properly in a very challenging case. So this is an image which you get following the exposure of the lateral spine via the lateral approach, or transpleural or retropleural. So you see here that the patient is on his right decubital position. You are standing behind the patient, and this is what you look through the microscope. You see the two segmented vertebrae, and between them you see in blue, in the upper pictures in red, in the under pictures in blue, segmentation of the herniated disc. And this is especially interesting in cases when you have a calcification of the disc, because when you expose the lateral side of the spine, you usually see just a big bone chunk, and you don't see any intervertebral discs, and you need to orient yourself, which is, in my opinion, not very easy with X-ray and with navigation too. There are other applications. For example, when you put an implant there, if you're doing a corpectomy and then you do the control CT, you can also do stuff like do the segmentation with auto segmentation, manual segmentation of the implant, and produce very nice pictures like this, which can then show you more intuitively, is your implant well implanted? And there is also a video to show this. Very short, just for the viewers to get to get a sense and feeling how does this look. So this was the case. Patient was operated in a previous clinic. And this is the intraoperative, this is the preoperative CT, which shows a calcified disc. These are now the intraoperative images with the segmentation following surgery. And this is a very crucial thing. This is what you see when you start to use your microscope. Now you see here two vertebrae. In yellow, you see the herniated disc in blue. And in that way, by adjusting the zoom or the focus of your microscope, you can always watch on the head-up displays, which are not on your microscope, but next to in your OR. You can always know where are you during the surgery, at which point of surgery are you at that very moment. So this is how it looks. You operate, you do your drilling out, and you have these outlines all the time present. And in every moment of the surgery, you know exactly where you are. Now, for older generation of surgeons to have these outlines all the time is, they get usually upset. Not my boss, but a lot of them. And there is a possibility to shut off these lines, to take it off, but you can still watch them on the head-up display, which is in the same OR as you. This was a very rewarding case because the patient profited a lot, and this is somewhat the end result. So you see that this is a three-dimensional reconstruction of the herniated disc, and it is exactly there where you would expected it to be, or where it actually was. And this is the intraoperative image following this is also a case of a herniated disc. You have here a segmented herniated disc in yellow. You have the dural sac in green. This is the fusion of the preoperative and postoperative imaging. You see here the retractor for the ITSLIP approach. You do the fusion, which is in spine, also very challenging. You need to have elastic and rigid fusion. This is the calibration of the microscope. This is throughout the surgery, and this is the end of the surgery where you see that the spinal cord has gone back to its place and that the posterior third of the vertebral bodies of two adjacent vertebrae and the herniated disc are drilled out. And in this side, you see on the left side, the preoperative, on the right side, the intraoperative imaging, which shows that the complete resection of the herniated disc. This was the herniated disc plus ossification of the posterior ligament. And this is the same patient with preoperative and postoperative imaging. And this is also one image from one of our publications, which shows the augmented outlines. We do change the color a bit, so sometimes dural sac is green, sometimes dural sac is red. It's not very intuitive always, but I think it explains the point very well. You can use it also for tailored corpectomies. In some cases, especially if you have a tumor case, sometimes it's very challenging to do a proper corpectomy and to place your vertebral implant. And ICT, although the cost of it is very high, especially if you are low or in middle income country, it's not for Germany, for UK or for the States, but for low and middle income countries, there is a significant cost to it. But it has a several very good sides. It has zero exposure for the personnel, for people who do the surgery. It has a very low exposure for patients, and it enables you automatic registration for the patient for the correct navigation and immediate intraoperative control. You can use it also in posterior surgery. You can use it for screws, as we heard in the talk before. You can use it for navigated placement of cages. This is another case, and this was published recently in World Neurosurgery. So the group from Marburg and the group of Roger Hertel from New York were the first group which published experience on augmented reality in intradural spine surgery. And this is one of our studies with around 40 or 50 patients who were operated in this technique. So this was a patient who underwent a resection of ependymoma. We first did a stabilization of the cervical spine because we did a 4-level laminectomy in order to get the ependymoma out, and to prevent the post-laminectomy kyphosis, we performed the stabilization surgery. And following the stabilization surgery, we did an intraoperative scan to control the implants, and we did the segmentation of all the implants and all the structures of interest in order to improve the orientation in the intraoperative field. Now, this case is a case where you don't actually need augmented reality because it's a straightforward surgery. You have microsurgical principles, but there are many cases where you have tumors where you need to get them completely out, and they have very tricky relations to important neurovascular structures. You have tumors which go around vertebral artery. You have en-bloc spondylectomies where you have a tumor which has a very tricky relations to all kinds of structures which you can segment in the preoperative imaging and superimpose in your augmented reality. So this would be the calibration of the microscope. So like I said, in this case, the reference area was put on the Mayfield clamp. The head was in the Mayfield clamp, but we usually tape it proximal to the field. And we did have also in that way a very, very high accuracy. But I would not do it for screw implantation. But for microscope-based resections, tailored resection, I think the accuracy which you get is enough. So you have here the outlines of all the screws, you have outlines of all the vertebrae, you have outlines of the tumors and of the spinal cord. And like I said, this is not the case where it is decisive to have this kind of surgery, but it shows very nicely what is augmented reality capable of. You see here the screws on the sides, how they are oriented. You see at every time where the tumor is. And what's also very interesting, and that was shown by Hertel and his group, when you open up the dura and you release the CSF, you virtually don't have any shift. And that is very interesting because in brain, when you let the CSF out, you have a major brain shift and the navigation goes wild. So like I said, we use this in straightforward cases in order to use it properly in hard cases. For example, in this case, this is a recurrent neurinoma of vertebra in the L5 on the right side with bony erosion of the vertebrae. These are the preoperative images. The patient had a surgery some 15 years ago. The neurema came again, the paresis, they needed to get done. So we've opened up the cetus, we've presented the scar tissue, and then we did the intraoperative CT and superimposed the preoperatively segmented structures on our intraoperative microscope. We also did a navigation update on the bony edges. And on this photo on the upper side on the left, you see all of the structures we have segmented. We have segmented the tumor with green, the tumor cyst with yellow, the dural sac in purple, or in, no, the vertebra is in purple and dural sac in blue. And this is all superimposed in real time on your operative microscope. So this is the way we found very easily the dural sac, opened it, and this is the kind of image which you then get when you look through your microscope. You have actually, with very high accuracy, you see the tumor, you see where the tumor cyst should be, and you see all other important relations to it. And this is how it looks under the operative microscope. And like I said, in cases like this, in cases where you have a tumor which is encasing very important neurovascular structures, I think this technology has future apart from producing very nice images which you can then show on a congress. And what we also done, and with that I'm going to conclude, is we have also put a 3D navigated ultrasound into the scheme. So you do a 3D scan and you fuse it with the navigation, and then you also have images like this where you do ultrasound scan on your operative field, and you get the segmented outlines also, which is also then very good because ultrasound is the only really immediate intraoperative.
Mirza, we lost you for the last second here. So Dr. Mirza maybe have some problem. We'll give it. Why don't we
Hi, Karina. Good to see you. Mohammed, I think it's brilliant German Wi-Fi.
We have people from all over the world, so it's gonna be difficult. So we'll come back if that was an amazing lecture by Dr. Mirza as usual. We'll come back to that then. I don't know if Dr. Teresa is still on. She may have left. So I know Dr. Karina has surgery this morning, so we'll let her go up next. She's going to be talking to us about machine vision. So Dr. Karina, go ahead.
Thank you so much, Mohammed. It's a pleasure to be here. Can you all see my screen?
Yes.
Okay, perfect. It's always really cool to see Mirza's talk on the augmented reality. And I'm really thrilled to be talking to you today about a different tool in spine surgery. I know today we get to hear about lots of exciting technologies, and I've been asked to speak specifically about machine vision guided navigation. It's not going to be quite as sexy as robotics or augmented reality. Here are my disclosures. I was a consultant in the past for the company that I'm speaking about, as well as for some other companies that do not have machine vision navigation. So I think the first question is why we should be using navigation or image guidance in the first place. My goal today is to hopefully convince you that this should be standard of care in your practice. I believe it's of utmost importance that we are placing our screws and doing our surgeries with the highest accuracy and high precision, because our job is truly very high stakes, okay? And a misplaced screw can be devastating for our patients. When we have looked at meta-analyses where we're comparing conventional, so freehand placement of screws throughout the entire spine, and we compare these to 2D placement with fluoroscopy versus 3D navigation, whether that's with any type of image, with any type of navigation modality that we'll talk about. We see across the board for cervical, thoracic, and lumbar screws, there is a significant increase in accuracy when you go from freehand to fluoroscopy to 3D navigation, where you're higher than 90% throughout all areas of the spine when you're using navigation. And one of our group's own meta-analyses of over 50,000 screws, we find that CT navigation has the highest accuracy compared to freehand and fluoroscopy. So, I put these images here to tell you freehand is essentially like a compass. Who of us would go to a new city and use a compass or an old-fashioned map to get around, right? None of us. We're all on GPS on our phones, and that's what 3D navigation provides us in the operating room. So I will preface this by saying that I actually use different imaging modalities and different navigation modalities in the operating room. So I still use traditional CT-guided modalities such as stealth navigation, for example. And I think that these are great for minimally invasive fusions, for example. So this is a patient who presented into our emergency department, a 77-year-old male, multiple medical comorbidities, including cardiac disease, COPD. He had a history of prostate cancer, and now he had a rising PSA with no known metastases. He came into another hospital with 5 days of lower back pain, progressive lower extremity weakness, and now unable to walk for the last 36 hours. He was full strength in his upper extremities. His right lower extremity was 3 proximally and 4s, and then 2 distally. And then he was also weak in his left lower extremity. You can see his imaging here showed multi-level metastatic disease with contrast enhancement in multiple vertebral bodies in the mid-thoracic spine, as well as with a dorsal epidural component that was causing severe spinal cord compression. So this is an example of a patient that I felt was a very good candidate for a minimally invasive fusion, given his cancer, the need for postoperative radiation and chemotherapy. So he underwent a multi-level spinal fusion as well and decompression for metastatic cancer. And this is with the O-arm and the stealth intraoperative navigation that I'm sure that many of you are familiar with. So I believe that stealth really is great in many conditions, and this basically applies to any type of intraoperative CT-guided navigation that needs an intraoperative CT scan. It can be great for patients that have trauma without significant compression, and this is specifically for MIS cases. It can be great for hybrid or mini open separation tumor surgeries like this one I showed you. I love to use this for degenerative disease with primarily foraminal stenosis if I treat them with inner bodies, for example, anteriorly, and then go posteriorly and use MIS navigation for that. And there's obviously many different pitfalls that can happen with this as we teach all of our residents and fellows in the operating room, optimizing our clamp placements, not touching the clamp because that means you need to get a repeat spin. And of course, navigation can be off if you manipulate, retract soft tissue too much. So now I'm going to go in and tell you about when I use this machine vision navigation in the operating room. So here's another case. This is a 52-year-old female who came in. She was a pedestrian versus auto. She had multiple traumas, including some very severe abdominal and aortic injuries that led her to go to the operating room multiple times with general surgery and CT surgery on her first day of admission. And she was also found to have this severe unstable T10 fracture. So when you're using some of our more traditional CT-guided based navigation platforms in the operating room, like the stealth navigation, if you have a patient with a really unstable spine like this, you certainly have options where you can place a clamp superiorly and inferiorly. But one of the things that I always worry about is when you have a really unstable spine, if your clamp moves relative to the spine, then obviously your navigation is going to be off and you're going to have to bring in your O-arm or your other device and get a repeat scan. So this is an example of a case where I think that the 7D machine vision navigation can be really useful. And that's what I ended up using in this particular case. So I'll take you through kind of step by step, first of all, how machine vision navigation works. So this machine vision navigation basically works using vision. So it's the same technology that you have, for example, in a Tesla with the self-driving car. And there are basically hundreds of cameras that are in the light that sits above the field. And can you guys see my arrow as I'm pointing to the screen? Yes or no? I can't see any.
So.
No, you can't see it. Okay.
Oh,
well, then
you
okay, great. So the cameras are present in this light. And this is what you bring in over the field. And so they take a picture of the actual of your actual operative field. And then they use that to co-register it with the preoperative CT scan that you've obtained for this patient. So as long as you get a CT scan that's less than 2 millimeter slice thickness, we usually aim for 0.625 before the surgery, you're able to get a picture of your operative field in a few seconds that you can then register with your preoperative scan. So that prevents you from having to bring in an O-arm or another machine and do a spin in the operating room. So I'll take you through this step by step. So if you have a case, you'll position the patient normally. You do need to use the C-arm in order to approximate the level and see where you are. And then in this case, and primarily when I use the machine vision navigation, I use it in open cases, okay? Because it relies on taking a picture of the field. So what that means is it's really important to make sure that you have a very good meticulous exposure. When I'm exposing the bone, I try to get all of the soft tissue out of the way. And it's also very important to not have a lot of blood in your field when you're taking this flash registration. This also has important implications for what types of cases this works best with, as I'll talk about, because you don't want to have a lot of shadowing because that interferes with the picture that you're taking. Also, if you have anything like a tumor that's involving the bone or other things that would interfere with your bony anatomy, you really need to keep that in mind because that's how this technology works. It needs to see some good bony anatomy in order to be able to register with your preoperative scan. So just like you would with any type of navigation, you have spinous process clamps and you place them near your region of interest. You want to be as close to the region of interest that you're going to be navigating as possible. And then you bring the 7D machine over the field. You take out other lights because those interfere with the 7D light. And then you take your flash registration. This takes a few seconds and you can see here it's literally taking a picture of the field. So you can see the clamp here. You can see the retractors in place. You want to make sure that you have good lighting and good visualization, especially over the levels that you're going to be doing. So then when you have your preoperative CT scan, you've selected points of interest that you know you're going to have well exposed, and then you bring your pointer in. This pointer has these balls that are being tracked by the 7D light, which is over your field, and you point to each of these points that you've selected. So it's really important if you're point picking, especially as you get into more complex cases, that you're sure to select points that are stable relative to your pedicles that you're going to be instrumenting, and that you're going to have well visualized and well exposed when you're doing the case. So you select these points. It then uses these to co-localize with your preoperative CT scan. So the image that is shown here has tons of green points. Each one of these green points is a successful co-localization. So you can see here, this is a very nice registration. And once again, this takes several seconds. So it's really quite fast. And at this point, you're able to now bring in your instruments and you can use navigated probes, navigated taps, navigated screw inserters with an image on your screen that's very similar to what you've been familiar with if you're using other types of navigation. And you're able to now place your screws. This is an example of what the navigated drill guide looks like. You can also use a navigated Lenke probe if that's of interest to you. You have a navigated tap to tap your trajectory. And then because this system is screw agnostic, you can use any type of screw. They do have a navigated screw inserter. I personally have gotten really used to using these virtual K-wires that they also have, which is definitely a different vision on the screen. It doesn't look like what you would see if you're using like a stealth platform, but there are these two lines and they show you in two planes. And so you can line up your instrument and place your screw with these. This is another example of a case that with which we use the machine vision navigation, and it worked very well. I'll say that at this point, I pretty much use it routinely in most of my open cases. I think it works great in cervical thoracic fusions. This is an example of a thoracic case with a calcified disc. This is kind of tying into some of the cases that Mirza was just showing us in the theme of calcified thoracic disc. So this patient had had a surgery at an outside hospital a while ago. They had done a unilateral fusion here, and you can see that there was quite a bit of this calcified disc that was still left. So one of the things that is that's great about this particular navigation platform, you can actually register off of the old hardware. So in this particular case, we picked our points, which were actually in the middle of the set screw, the rod, and this and the set screw. And this allowed us to do a very nice navigation. And then we were able to use the navigation to both place our screws as well as to see where we were when we were doing our drilling and to ensure that we had taken off the majority of the thoracic disc as we wanted, of this calcified disc as we wanted to. And we did this through a posterior approach. But I use this case to show that you can use the 7D technology even in revision cases. And this is what our postoperative x-rays looked like. One other potential advantage is that you can also do a CT angiogram. So we're routinely doing CT scans at 0.625 millimeter thickness with a soft tissue window for the 7D platform. But you can also get it if you're concerned about any vertebral anatomy, for example, in a C1-2 fusion. This is a patient, an older patient with severe osteoporosis and a non-healing displaced type 2 odontoid fracture. You can actually do a preoperative CTA. And so then when you're doing your navigation, you can actually see exactly where you are relative to the vertebral anatomy. So that's kind of a cool use in this particular case. You can see the points that we selected on the C1 arch in order, and with a very, very nice registration with high accuracy in order to place our C1 screw. And these are the points that we selected on C2, once again, with a really nice registration for us to place our posterior C1 and 2 screws in this case. You can see here as you're bringing up the instruments and how your image looks on the monitor. And in particular, you can see where the vertebral artery is relative to the screws that you're placing. And then you can see our postoperative imaging here. So in terms of pearls and pitfalls, this particular machine vision navigation can be great for open cases where large open decompressions are needed. It can be really great for the unstable spinal fractures, like that first case I started with the woman who had the very unstable T10 fracture. You can imagine that if you're using another type of navigation platform, if your spine is moving relative to the clamp, you're going to be inaccurate. You're going to have to bring in your O-arm and get a repeat scan, which takes time. But it's really important, and I always teach our residents and fellows that for 7D, in order for it to work well, you really need a very meticulous bony exposure with soft tissue removal and suctioning of any blood in the field. You have to really pay attention to lighting and shadows during your flash. So keep in mind, this can mean that you need to select blocks at the both superior and inferior aspects of your incision in order to make sure that you have good registration at the top and the bottom. You really do need to think about and optimize your point picking, and this is something that I've learned using this technology, your points on that mobile gills fragment. So there's lots of things like that that you need to keep in mind. There's also a different line of sight than stealth. So I showed you that the cameras are in the light, which is over your surgical field. So when we use some of the other navigation platforms, we get used to pointing all of our instruments towards either the head or the foot of the bed. And oftentimes our heads are over the field. Well, when your head goes over the field, sometimes you can block the light from directly over with the machine vision navigation navigation. And so that's something you need to keep in mind. And I really do think that, at least in my hands, some of the most challenging cases are these one-level lumbar fusions, because there's a lot of shadowing and it's hard to get a good registration. So I don't routinely use this in 1 or 2 level lumbar fusions. In terms of comparisons to other symptoms, I feel that it does have a better workflow because you don't need to get this intraoperative O-arm spin, which can take significant time. It's really easy to obtain repeat flash registrations if your clamp moves. So I didn't explicitly state this, but when you're selecting your registrations, you usually register in blocks. So let's say you're doing a C2 to T2 posterior decompression and fusion. You're likely going to be doing a separate flash registration for C2, 3, 4 to 6, and maybe C7 to T2. And you get all of those separately. Each one of those takes a few seconds in order to get, and the whole sort of registration takes about a minute or 2. So it's really quite short. So if you have any time in the case where your clamp moves, all you need to do is repeat this, and it really will only take you a minute or 2 in order to fix your problem. There's some papers showing decreased intraop radiation exposure, obviously, if you're not taking multiple C-arms or O-arm spins. Disadvantages, I don't feel that it works well for MIS. They do have a workaround for it, but essentially this is a machine vision guided technology. It's taking pictures of the field. You need meticulous bony exposure, and we talked about some of the exposure and shadowing limitations. Here's a really nice paper coming out from the HSS group comparing the efficacy of the machine vision technology to traditional 2D fluoroscopy. And what they can see here is that there's a very significant decrease in intraoperative fluoroscopy dose while maintaining excellent grade A Gertzbein-Robbins pedicle screw accuracy when you're using the machine vision navigation. So in conclusions, I feel that navigation is truly becoming the gold standard. I use it every single day in my practice. I believe that different navigation platforms have specific advantages and disadvantages, as I've talked about today, and machine vision image guidance can improve intraoperative workflow and decrease radiation exposure in the majority of open posterior spinal fusions. But I do feel that CT-guided navigation remains the preferred MIS workflow, and I'm happy to take any questions.
Thank you so much, Dr. Karina. Brilliant work as usual. We have time for 1 or 2 questions. I think you've blown them away, so they're still in shock of what they saw. So work as usual. Oh, Dr. Let's do it, Dr. Teresa.
Awesome.
Teresa.
Yes. Thank you guys so much.
Dr. Williamson, do you have a question?
Teresa, have a question.
There we go. Thank you. I wasn't allowed to unmute. Great talk. I was just curious what you think, what are the changes that need to happen for it to be more MIS suitable?
Well, they have a workaround for it. But honestly, I haven't even tried to get it because you have to bring in, you need the field, right? It's fundamentally not designed for MIS, right? Because MIS, all you would be doing is looking at the skin. So they have a workaround workflow where you bring in the O-arm, et cetera. So if you are, so let's say if you're at a hospital that doesn't have any type of navigation device, right? And you're trying to figure out, which one should you get? I think, obviously every hospital and in every country, there's going to be different pricing. Generally speaking, I think the 7D, they tend to price themselves a little bit lower. They're not super cheap, but they certainly are lower than some of the other platforms. And you can theoretically but that is something to be aware of. But essentially, it just takes away what I consider to be one of the biggest advantages of 7D in that, you don't have to get that intraoperative O-arm. So that's like the big workflow advantage for me. So they do have a workaround for it, but you have to, if you don't have a picture of the field, because all you have is skin because you're doing MIS, then you have to bring in some type of, O-arm or other device to get the intraoperative CT scan. So I mean, that's kind of like the fundamental issue with it.
I think that answers Dr. Fatah's question. So we will go on to the next speaker, which is Dr. Francesco, who always gives a great talk on simulation. So, we do all this amazing work in the operating room, but we have to teach our trainees and sometimes even ourselves get better before we do these surgeries in patients. So Dr. Francesco.
Yes, one moment that I share my desktop. Okay, you see my monitor, my presentation is correct? Okay, thank you very much for the kind presentation, and thank you very much to Mehmet for this opportunity to combine the activity of our two committee. We have seen in the previous talk the role of the new technology in operating room, so how the navigation, how the augmented reality can help us to better understand the anatomy in difficult cases in order how to manage. But before to reach this level, we have to think how to have an effective way to learn our work. We know that the surgery is a matter of knowledge, competence, performance, and action. And the way that we reach all these competence define and how fast we reach it, define our learning curve. And in surgery, we must advise a steep learning curve. That it means few repetition to reach the goal and to reach the our standard. But how we can define the teaching program? We know that for surgery right now the courses and cadaver labs represent the gold standard, and there are several opportunities right now worldwide. Here some example is the last that we did in Cape Town during the WFNS Congress. And we know from the literature that the experience of the participant with cadaver lab that is increase the operative skill, the anatomy knowledge, and the technical performance. But we know that cadaver lab do not provide operating specific pathology, have some high maintenance costs. The quality of the cadaver sometimes is not so good, and in some countries there is also some ethical implication that we have to keep in mind. So in order to reach a good experience, we can learn during the surgery or with the courses. But sometimes when we hand the program, the residency program, we know the theory, but when we pass to perform, we have some troubles, and sometimes it's very difficult to understand. So what is the real way to perform and to have a good learning curve? What is ethical and what is safe during our daily practice? That is the real question. So for answer this question, can the technology help us in this program? We know that right now the imaging evolution, the real-time navigation, the use of robots, augmented reality help during the surgery, and we have seen really fantastic cases by the other authors before me that help the surgeon to better understand anatomy, and this is essential. But some companies develop also some simulations, some models. There are simulators that can help in the teaching program. We know that the augmented reality and simulation have changed the way in other fields. I'm thinking about the military, the aviation, because simulator also the sportive driver that use simulation in order to repeat and repeat the performance and to reach the potency of the work. And the correlation between neurosurgery and, for instance, aviation and the training for the pilots is not new. Now there is a new program in the Besta Institute that is called Astronaut, because it's compare the teaching program of the astronaut with the neurosurgery. So it's something that it's changing over the years, and it's work. And the interest in the literature, if we found the word simulation and neurosurgery, we see that in the last 10 10 years, 15 years, there is a high increase of publication regarding these topics. And the connection between simulation and neurosurgery is not new, probably due to the particular issue of our task in brain surgery to understand the three-dimensionality and the function of the brain and of the spinal cord. So is something that is in our specialty is really there is a kind of connection. And right now, this is a very new review of the literature, and we know that the role of simulator of the models in the training program is more and more accepted. But what are the simulations right now available on the market? We have different kinds of simulator. Maybe someone is based on computer or using with the iPhone or with the pad that simulate the anatomy. We can perform the different step of the surgery, but we have the complete lack of the haptic feedback for the surgical and the skill steps. The models provide a specific anatomy, so we can reproduce in a lab, so we don't need a wet lab, but we can work also in a room with the specific tools that help us. Yeah, a very short video for a posterior cervical laminectomy. You can see that I'm working in a lab, and we can reproduce with this model with a pretty high good quality the surgical intervention. So this model helps to, sorry, I can skip the video right now just to be in time. But probably the connection and the future will be introduce the virtual reality and the augmented reality also in the teaching program in order that we have a full immersive experience of the operating room and to simulate the surgical procedure. And the goal is to create the opportunities to have the feedback haptic of the singular steps and to do and redo every time we need the surgical intervention. So we know that with virtual reality, we have the mental training. With the augmented reality, there is a hybrid training. And then with the models, we have the haptic and manual experience. I can show some studies that are running right now. This is one that Corinna with also with Harvard University with I speak with her. They develop in order to standardize the program for the anterior cervical surgery. They define a way to teach to all the residents, so an introductory video to perform the technical notes and then to perform the surgical steps. So every resident have a model so they can repeat more times the surgical approach. So they are in a lab, in a room, and there is a tutor that follow them, and then they analyze the results. Here the results 21 residents from the two universities, and very quick all the time, all the experience and the feeling of the resident were recorded, and finally the resident that participated to these studies defined that there is a better knowledge of the anatomy in the post-training that is statistically significant, and also the timing of each singular procedure were better in the time. So we know that repetition is good. This is our study that we are running out right now in University of Milan in Besta Institute, where we compare different way of reproduce surgical step with a simulator, with spine models, and then the last step with the cadaver lab. And we are studying the different group. We divide the residents in 3 groups, one that will receive all the 3 different steps, one that will receive the models and only cadaver lab, and one that is the classical way of teaching. This is the objective is to try to understand how the simulator and the models can affect the teaching program, because right now we know that our useful, but the real impact of these tools is not very clear. Every people receive a short video showing the lecture and the demonstration on how it works. This is augmented velocity, just to show how it works and how must be performed the procedure. All participants receive the same lesson at the beginning. Then we analyze the results of accuracy, timing, and number of X-ray scan. And we also analyze with an MNG registration the muscular activation from the beginner, from the resident, and from expert surgeon, in order to weigh how the repetition can change the muscular fatigue during this procedure. Yeah, an example. I am always the first to perform this experiment because I tried by myself. And here the result we show with the simulator, so is the step 1 of the study, that with almost six repetition, the resident reach a plateau with better results. Then regarding the X-ray, the number of X-ray, again, we define the plateau in order to define how many repetitions are necessary to standardize the number of control. And we analyze of the data according to the experience with the year of residency, with the previous experience on a simulator, on cadaver lab, or in a surgical operating room, and also in gaming, because I'm thinking that the people with work and who have a very experience in gaming probably are faster in to understand the use of these tools, and this is correct. Now, regarding the muscular activation, we show that a novice have a less satisfied and with a more muscular implication, so there is more fatigue and the movement are less precise. With the trainer, we see some differences, and with the expert, we see that the activation is very selected for the muscular that we need. And again, for the expert surgeon, the use of dominant hand and non-dominant hand remain essential in order that with the non-dominant hands, it's helped the dominant hands during the procedure. So it's very interesting, and but it's just at the beginning. And now is under review, so in the future we will see the result. But what is the reality all around the world regarding the training program? I found this very interesting paper that is based on US, where there was a survey regarding the role of the simulator of models, and finally the director showed that the role in the future for simulation and physical models will be represent almost the 80% of the activity in the training program. So as a new technology, we start to have some different kinds of tools, and probably will be adapted more and more in the different universities. In conclusion, I think that simulation and a three-dimensional model are very interesting, promising tools in the training program in spine surgery, but not only, obviously. But I think that we have to think like society to better standardize this teaching program in order to have a more uniform education worldwide, especially if these tools can be reach a good cost effectiveness. So some studies to define their real implication in worldwide are essential. So thank you very much for your attention. And if there is some question, I will be happy to answer.
Thank you so much, Dr. Francesco. Amazing work as always. I really like to see this EMG results and the stress and so on that goes on with surgery and the difference between the different training. I'll open it up to any questions on the chat or
the MG study is very interesting because we know that I was going to your comment that is really interesting. The MG study, we are just analyzing the first step. We are just working on the second setup with the different models, and is quite interesting to see how we change over the time, not only in timing of procedure and accuracy for the keyword, but also in the fatigue of the resident. Is interesting.
Yeah, Dr. Salman is asking about the cost, and that was
Oh,
also
Salman, I saw. Yeah. Right now, for the simulator,
it's too much.
yeah,
Yeah. So how can we bring it down?
it's too much. Yeah, right now some models are.
Sorry, go on.
Yeah, I know that some companies try to find the different material in order to reduce the cost, because right now the cost of a model is cheaper than a cadaver lab, but is too expensive to use worldwide in all scenarios. Little bit better is the simulator, the one that I show for the keywire, have an initial cost, but you can use infinite ways and infinite times. So you have only an initial cost, but finally you can use year by years, and really there is some residents that perform the different difficulties 100, 200 of times because was there. So when it was free, he start using, and there is really his feedback change over the time. For the models, obviously are the best future, because we can probably in the future we can consider also to have anatomy specific or pathology specific models, but as you explained, the costs right now are pretty high to be usable for all the centers.
Okay, great. I think I'm the last speaker. It's hard to follow such amazing speakers. So I'm going to be talking about robotics. Let's see here. Can you guys see my screen?
Yes.
Okay, perfect. So here are my disclosures. And so for those people that are in the United States, I will be talking about some off-label applications. So in terms of our objectives today, we'll talk about the motivation about why we'd be interested in robotics. And we'll talk about some advanced applications for robotics in spine. We'll talk about percutaneous TLIF as it relates to Camden's triangle. We'll talk about advanced spinal pelvic fixation, and we'll introduce the concept of the transfacet TLIF. So if we look at a robot, if you look by definition, it should be a machine that resembles a human being. And so that's not what we have right now. What we have right now is more of a cobot, something that is a computer-aided robotic device designed to assist the person. So I know in some of these movies, it's the robot is fully autonomous and doing all the work by itself, but that's not what we have. Right now, what we have is basically a very expensive drill guide. So here is a picture, video of how it works. It gets you in the trajectory, but you still, as a surgeon, have to put in the screw by yourself. And so that's what we currently have. And so whenever you have a new technology, you have this, what we call a hype cycle. So there's a lot of excitement that happens, and then you start having some negative press. I think that some people in the United States may have seen that there was recently a warning to one of the robotic companies about their technology. And so you start having some negative press, and then you start having some problems, and then maybe you reach some type of equilibrium where we figure out, okay, this is the best application for this technology. If we look at the chasm of implementing a new technology, there's usually this gray zone whether we're going to cross that chasm. And this, whether you cross this chasm, I think depends on how low this disappointment is. So if this disappointment is very, very low, then you may not cross that chasm. And so traditionally, sometimes we have this thing where we start thinking about us versus them. So man versus machine. So some of the younger people may not know who Garry Kasparov is. I asked one of the residents, they had no idea, but I'm old enough to remember this. So Garry was playing against this Deep Blue IBM computer, and you can see the stress on his face because he felt that he had the world, the pressure of the world on him. This was in 1997. If you fast forward for 20 years, you see that he preaches a different scripture now. Now he says, you know, machines have calculations, we have understanding. And so we actually should not look at the machines and robotics and so on as a adversary, but rather something to help us achieve our goals. So if we look at, you know, what's going to be the ideal navigation or imaging system, we've had brilliant talks by my colleagues. We really want to have real-time imaging. We want to avoid fixating on the patient. If we can avoid a preoperative CT, that would be great. We should be able to recalibrate easy. I love the work that Dr. Mirza was doing with the ultrasound. We want to decrease radiation, and we should not increase OR time. Right now, the current iteration of robotics don't do any of the top four. But that doesn't mean that it's not going to happen. It's just that that's the iteration that we have right now. So can we use the robot for applications other than placement of pedicle screws? So one of the great things about a robot is that it is able to target deep structures, and it could do that while decreasing the damage to overlying tissues, and we don't have to do a lot of dissection. So we use this actually to target Camden's triangle. I had a previous webinar this morning on Camden's triangle. And so we can see that Camden's triangle can be a very deep space, and it can be very, very small. And to target it could be very tricky, but we've used the robot actually for this application. So here's a patient, 64-year-old gentleman who had previous problems with general anesthesia, did not want to have general anesthesia, and he had a spondylolisthesis at L5-S1. So we're able to target the pedicles using the robot, but then also target Camden's triangle. So then we're able to place an intrabody fusion using this. We do this ESP block as well as a spinal anesthesia. We have the patient awake, and then we put in the screws as traditionally, and then we're actually able to target Camden's triangle. And so you can see in this case here, there's no blood loss. It's a percutaneous case, and these patients in general do very well. We published a case series about this using the robot to do that. And we can see that, you know, we had 10 cases, 4 of them were done awake. Our EBL, because it's percutaneous, is less than 100 cc's. And you can see now most of our length of stays is in 0s and 1s. How about percutaneous iliac fixation? This for tumors and unstable sacral pelvic fractures. So here's a gentleman who had a invasive colorectal carcinoma. He had this very metastatic and large cancer here. And then if you look very carefully at a CT scan, he had this sacral insufficiency fracture here. And so, you know, how do you treat this patient? He has very bad kind of prognosis, but he has a lot of pain. So what we do now is we can plan the screws in the lumbar spine. And then this is where I think the real power of the robotics is that you can actually plan the tulip heads all line up together underneath the skin. And so then you can do these cases percutaneous. So these are the Wiltse incisions that we did for the lumbar screws. And then this incision here is for the iliac screw that went in this way. And so it always is very challenging when I'm doing it with fellows. They're like, oh no, Dr. Abdul-Bar, there's something wrong. And I tell them, no, there's nothing wrong. What happens is underneath the skin, the tulip heads line up. And this is very difficult to do as a human being. And so you can do this case now. This was our first case we ever did, was 150 cc blood loss, but now we're going to get down to 20 and 30 cc blood loss. And our construct looks like everybody else's, but it's completely percutaneous. We can get this patient home post-op day 1. He only ended up living for 3 to 4 months after his diagnosis, but at least we gave him some quality of life. How about unstable sacral fractures? These can be in terms of high velocity traumas or old people with insufficiency fractures and fragility fractures. So here's a 65-year-old lady. She had a head-on motor vehicle accident. A lot of these patients, have deep vein thrombosis. So you don't want to do a big decompression, because then you're going to have to put them on blood thinners and so on. So if we can do this all percutaneously, that would be great. You can see here just how comminuted her sacral fracture is. So this is done in coordination with our trauma colleagues. So here they had an acetabular fracture. They do all this, and then we are kind of sometimes dodging their metal. So we can do this again, completely percutaneous, 25 cc blood loss, right? And now we can put her on blood thinners faster. She's 2 years out and extremely happy with her abilities to walk and so on. I don't think we could have done this any other way. And sometimes it's challenging. They have external fixation devices. They have 2 to 3 transiliac, transsacral screws, but we can still kind of dodge metal there. So this is our original case series, and we've had some really good results. We had one complication that we had. How about the transfacet TLIF? So, we've been very obsessed with Camden's triangle, but as we've learned more, we found that some people's Camden's triangle is just too small to put a safe interbody fusion there. And that's really gotten us to think about this transfacet pathway, which is keeping the facet joint in the middle of our trajectory into the disc. We've published this paper looking at these different pathways. Here's a case I think I showed at the previous webinar, 35-year-old. We do this transfacet pathway. Now we've actually set the table, and we haven't done this yet in a human, but I hope in the next few months, where we've actually shown that you can dock the robot on the facet joint and hopefully use the robot then to do the interbody fusion and do this completely percutaneous. So in terms of future directions, I think intelligent decompression, I think will definitely be there. One of the things right now, the robotic heart technology is a little bit slow. So I call it sometimes affectionately the slow bot. And I think I'm faster. I call myself the Mobot. But at some day, the slow bot will get faster. And then more versatile end effectors are coming down the pipeline. So just to conclude, I think robotic surgery is an emerging and exciting field of spine surgery. I think beyond placement of pedicle screws, I think there are a lot of other applications that the robot can be very helpful for. And with that, I'll conclude. Thank you.
Thank you very much for your really interesting and a very nice presentation. Do there is some question about this topic? I have a question, if I can. Yes, is on the same way of the one of Salman. We know that the technology, especially at the beginning, are very have a very high cost. In your opinion, what must be the break-even points of surgery to justify this technology? And I mean, all the centers that have spine surgery may use this technology, or in your experience, there is some specific indication or a number of procedures that give a cost effectiveness of this technology, as right now is very, very expensive?
Yeah, that's a great question. I think that as it stands now, the robots are extremely expensive. They are very slow. And so I think using them for certain indications makes sense. I think that the indications that I like to use the robot for are with these spinal pelvic fixation, where I can do everything percutaneously. I don't think that even the regular navigation will allow you to, really plan out and make it very precise where you put those tulip heads, and so that you can do these cases completely percutaneous, especially if there's previous instrumentation, these transiliac screws that get in your way and so on. So you can really, it has the advantage of amazing navigation, but then also the implementation is perfect, right? And so as we know, just because you can plan it very well doesn't mean as humans we implement it very well. So I use the robot for distinct cases, not all the time. I think for a 1-level or 2-level fusion, the Mobot is still faster than the slow bot.
Mohammed, excellent talk. I like it, especially the sarcopelvic fixation by the robot. But is there, as you have mentioned, is there a way that we will use the robot as in the similar to the abdominal surgeons in tumor resections, even in intradural tumor resections? Do you think there will be a time to come for this?
Yeah, great question. So I was doing a very difficult case a couple of days ago, where we have to do very precise dissection. And I told the resident, do you think the robot can do this? And currently, no, right? And we can't lose our surgical skills. But I do think that in the future that may be coming down the line. But right now, the technology is just not there. I think we still need to learn how to dissect soft tissue and so on. But maybe in the future it will happen. Dr. Teresa,
Yeah.
For you.
Thanks so much. That was a great talk. Always fun to learn from you, and fun to reflect on being part of that hype period of the robot training with you and under you down at Duke. My question was around your case on the spinal pelvic fixation. 2 questions. One, with the Wiltse incision, have you considered doing like a midline incision to the fascia? Just because those for the S2AI screws, the incisions are so medial compared to your pedicle screw incisions. And then the second question was about fusion. So, I'm getting tempted to use the robot to do this for like MIS, T10 to pelvis, etc. Obviously, this was a very different case. It was more of a palliative surgery for someone for stabilization. But are you comfortable at this point feeling like you get a good fusion to do it for more of a degen case?
Yeah, great question. So the first question about the Wiltse, that was our very first case, and right now we're actually not doing Wiltses. We're mostly doing them as just percutaneous, just stab incisions. So usually, there isn't a need to do midline, and so I've kind of gone away from that. So not a lot of times will I do Wiltse incisions, and I think that was just our first kind of through the learning curve. In terms of fusion, I think that's a really good question. I think that I don't know the answer to that. We've had, knock on wood, some really good experience with them in the traumatic field. But in terms of, for long segment fusions, are we going to be able to fuse across that segment or not? I don't know the answer to that at this point. Okay, well, it's been a real pleasure having everybody on this webinar. I think I've learned more than you know, I actually taught today, and it's so great to see people from all over the world. And thank you, Dr. Mehmet, for setting this up. I think this is a great first start to the collaboration between all the different WFNS committees.
Really, it was great. I enjoyed all the speakers. Thanks a lot. We should see you again.
Bye.
Bye. Thank you very much.
Bye.